Okay, hello, good evening to all our doctors. Today we are going to start breast and endocrine surgery, eMRCS question bank. Our information today, what we have about more than 60 or 65 MCQ. I hope to finish them all today. Don't be shocked by the maybe some non-surgeons about problems of the breast and thyroid and other endocrine system in the body. But as I say every time, and I just want to remind every time also, that we just need some superficial information. He needs you to know some basics and basics of basics, not all basics. Just very simple questions, broad questions that you can manage in your clinic, and how you can direct the patient with few information to the main specialty. Even some surgeons don't know all these informations. But here, he just wants to tell you some simple, broad information about some diseases. And most common diseases, it is very rare to ask about rare diseases, but he wants to explain with you some common diseases and how you can direct the patient and how can you deal with this patient simply, or how you can direct the patient to the specific specialty. Okay, so we'll start now with Dr. Farah, our first question. You can read and answer, Dr. Farah.
A 43-year-old lady is diagnosed as having a malignant lesion in inferior aspect of her left breast. There is palpable axillary lymphadenopathy. What's the most appropriate course of action? Mastectomy and axillary node clearance, wide local excision and axillary node clearance, wide local excision and sentinel lymph node biopsy, image-guided FNA of the axillary nodes, and CT scanning of the chest, abdomen, and pelvis. Since the patient has a malignant lesion in the inferior aspect of the breast and there is a palpable axillary lymphadenopathy, so we have to see whether this axillary lymphadenopathy is malignant. So for that, we can go for image-guided FNA of the axillary nodes. The option.
Yes, exactly. Anyone have different answer or another opinion? Okay, so what he wants to tell us simply here, he wants to tell you if, yeah, I'll start from the start of a patient come to your clinic and you examine this patient and she's middle-aged and you find a mass in the breast. First, when you examine this patient, you examine the breast and the axilla. Yes, breast and axilla, and then you ask for, after examination, you'll ask for investigation, which will be start by non-invasive investigation. Whatever, if she's young age, you'll go for ultrasound, and if she is old age or more than 50, 40, or 35 to 40, according to every clinic policy or every country policy, you go for mammography. And then when you doubt any malignancy or to confirm your diagnosis, you go for fine needle true cut biopsy. And for the axillary lymph node, you go for fine needle aspiration cytology. Okay. All the question here, he wants you to know this next step. So if he told you you palpate a mass, what's your next step? You'll go for biopsy. But if you have the biopsy, what about the lymph node? He wants to know two things about the lymph nodes. If you can't feel the lymph nodes, or you can't see it, or you can feel the lymph node, or you can see it by ultrasound, you have to do the fine needle aspiration cytology. But if you can't feel lymph nodes, or you can't see lymph nodes by ultrasound, during the biopsy or during the operation, you have to take a sentinel lymph node biopsy. And mostly nowadays, they do it as frozen section. So intraoperative, they can decide even, they can go for lymph node, axillary lymph node clearance, or just leave it, there is no metastasis. Okay?
Okay.
What he wants to know also about the management options for the lymph breast mass. He wants to tell you, if we have a small lesion in one quadrant of the breast, we can go for wide local excision. But if we have multiple or large or central lesion, we will go for simple mastectomy. According to the Royal College here, we didn't see any case with radical mastectomy. They do simple mastectomy plus axillary lymph node clearance, and then they give something like radiotherapy to the breast, especially for the wide local excision. But they say that radical mastectomy is a historical and aggressive operation and gives the same results like simple mastectomy with removal of the mass and clearance of the axillary lymph nodes. Maybe this is simply what he wants you to know about the breast, or how you think about the breast mass. Where is the mass? What is the nature of the mass? Do you see axillary lymph nodes, or you can't? If you see, take a biopsy. If you can't see, go for sentinel lymph node biopsy intraoperative. Okay?
Okay.
I hope it's clear. And then, according to our scenario here, you have a mass, and you diagnose this is a malignant mass, and then you have palpate axillary lymph node. You can't go for the operation without having a biopsy from this lymph node, so you can stand over what is the diagnosis. This is malignant, or just inflammation, or just reaction. So during the operation, you can decide if you will go for clearance, axillary lymph node clearance, or just wide local excision. Okay? Let's go for the next question, Dr. Ghada.
44-year-old lady presents with a mass lesion in the upper outer quadrant of the left breast. On clinical examination, she has 2 cm mass lesion, which on core biopsy is demonstrated to have invasive ductal carcinoma. An FNA of a bulky axillary lymph node contains malignant cells. What is the course of action? Correct course of action: wide local excision and axillary node clearance, radical mastectomy and axillary node clearance, simple mastectomy and sentinel lymph node biopsy, wide local excision and sentinel node biopsy, or excision biopsy and sentinel node biopsy. Well, she has invasive ductal carcinoma, And there is axillary palpable lymph node, so no need for sentinel lymph node. In case of invasive ductal carcinoma, it's either wide local excision or mastectomy. So, axillary node clearance, radical mastectomy, it's not more using nowadays. So I think wide local excision and axillary node clearance, A.
Anyone has different answer or another opinion?
I think it's right. Wide local excision and axillary node clearance.
Okay, Dr. Dafur the same, Dr. Muhammad also the same, a wide local excision. So, according to what we said, we have a mass and we diagnose the mass, it is malignant, and we have palpable axillary lymph node. We did FNA, we find it's malignant. So we'll go for, this is a small mass, so we'll go for wide local excision.
And it's ductal, not globular. If it, yes.
If it's globular, mostly it will be multifocal.
Yes. Unifocal and less than 4 cm.
Yes, this is 2 centimeter.
Not central, it's in upper outer quadrant.
Yes, so it's small and in one side of the breast or one of the 4 quadrants of the breast. We said if it is central, large, or multifocal, we'll go for simple mastectomy. Okay, and
simple mastectomy.
Simple mastectomy. They say also we can read it here. Although the primary region is small enough for breast cancer, the presence of axillary lymph nodes will attract for recommendation for axillary node clearance. Note that excisional biopsy is not appropriate for any malignant case. Okay. It will be clear, our idea will be clear in the next few questions, by the way. Here is the comparison about where to do mastectomy and when to do mastectomy and when to do wide local excision. This is multifocal, this is solitary, this is central, this is peripheral, large and small, small and large, more than 4 centimeters, less than 4 centimeters. Patient choice also is a main important factor in deciding what to do in the operation. Okay, so next question, Dr. Dafur.
43 years old lady has recently undergone wide local excision and sentinel lymph node biopsy for carcinoma of the breast. On the factor listing below, which will provide the most important prognostic factor? Mitotic number, grade, nodal state, size, and stage. Is nodal stage.
Nodal states. All agree?
Yes.
No, there is one said E.
Estrogen.
One of them, yes.
Dr. Muhammad.
Yeah.
Lymph node status.
Okay. Yes, it's according to the Royal College and the NHS in England, the nodal status is the most important, single most important prognostic factor in breast cancer. Okay. May I did read it in some books about the estrogen receptor status, but maybe he's talking about some pathological review when you look for the pathology for any type of malignant. What is the most important thing you have to look to? You have to look for the estrogen and progesterone receptor. You have to look to the HER receptor, HER2 receptor, and you have to look to the Ki-65, 67 as well. These 3 are very important in completion of management of any any mass in the breast, and you have to look in the pathology report. And by the way, in part B, you have a question and he will give you a pathology report in the station, and he tell you what is the most important things. So you have to post to these indicators, and you have to look to the margins of the tumor, and you have to look to the lymph node status as well. But if you were talking in public, what is the most important prognostic factor is the lymph node status. Okay. Next question. Who's ready? Dr. Burhan, if he's ready.
Yeah, sure. A 53-year-old lady has recently entered the UK from Far East, and she undergoes thyroidectomy for a very large multinodular goiter with uterosternal extension. The operation is relatively straightforward otherwise. The patient is returned to the recovery area and suddenly becomes profound dyspneic and hypoxic. On examination, the wound is healthy, dry, and drain empty. What is the most likely cause? Contained hematoma, unilateral laryngeal nerve injury, unilateral superior laryngeal nerve injury, tracheomalacia, hypocalcemia. I think it's A.
You think it's a contained hematoma, yeah?
Yeah.
Okay, so, but he's in the scenario, if you came back to the scenario, he said the wound is healthy and dry and the drain is empty. So it doesn't attract your attention about that is nothing or another thing than the bleeding inside the wound.
In that case,
the operation is straightforward. The patient returned to the recovery area and suddenly the patient is still in the recovery. And this is very fast problem or complication that happened.
I think it is tracheomalacia and then.
Exactly. This is one of the most common, yes, big research. One of the most common complication of a big, long-standing retrosternal thyroid is tracheomalacia. This is a long-standing, and they say that in UK, according to the continuous survey and continuous checking of their patient, all covered by insurance, and they have a full. They should have nowadays. They should have a full insurance and a good insurance system and a good health system. So they rarely find a large multinodular goiter and retrosternal for long-standing time. But that's why he said a lady recently entered the UK. So they want to tell you that we have a very good health insurance and health system. So we don't miss a case like this. But here we have to say, okay, no problem. So this patient coming from outside UK, and she finds that she have a long-standing retrosternal goiter, and this one of the main complications is tracheomalacia. Other complications like unilateral recurrent superior laryngeal, all this complication, I think intraoperative will be noticed by the anesthesia. Hematoma, he canceled it, or by the healthy dry wound and drain. And hypocalcemia will give another complications or another clinical picture other than this picture in the scenario. Okay?
All right, thank you very much.
Okay, next question. Dr. Ismail, if ready. If not ready, Dr. Farah again.
Okay. Ready?
Okay, but please, I just want you to close to the mic and just loud, clear voice, please.
Okay. Like this. A
Okay.
45-year-old lady presented with a 2 centimeter mobile breast mass. A mammogram is indeterminate M3. Ultrasound shows benign changes U2. Clinical examination is also indeterminate P3. What is the next most appropriate course of action? طيب, reassure and discharge, fine needle aspiration cytology, excision biopsy, image guided core biopsy, wide local excision. Fine needle aspiration cytology.
Is it a cyst or a mass?
Mass.
So in breast, we do a fine needle aspiration cytology, except for a cystic lesion, or what we do.
Okay. Image guided core biopsy.
Exactly. Yes. In breast, as we said, we go for fine needle, core biopsy. We go for examination, then ultrasound or mammo. Okay, thyroid, fine needle, yeah. And then after we go for core biopsy, then search for lymph nodes. You palpate, or by ultrasound you can see. We go for FNA, okay. But if you can't see or negative by examination or ultrasound, you go for sentinel lymph node. Okay. This is the scenario you go for. If you just did the examination, you go for the ultrasound. You have the ultrasound, go for the biopsy. You have the biopsy, go for the lymph node. Then you go for the definite treatment. Okay.
Okay. Just a question.
Sorry?
I have a question.
Yes, okay.
Here.
Yeah.
Okay. Okay, we have this concordant finding. Mammogram, it said ME3, while ultrasound, it's U2. On examination, it's a suspicious mass because it's P3. So there is a palpable mass. We need a biopsy here just to connect all these findings. It's this concordance between the examination and the imaging finding. And there's 2 imaging finding, everyone aside with different scale. Okay. So we need a biopsy here. The question is, if it is not palpable, there is a rule. It said we can use a wire-guided excisional biopsy. If it is palpable, it's either core biopsy or excisional biopsy. My question is, when to use excisional biopsy per se, and when, so I depend on core biopsy.
When you do excisional biopsy?
Yes, and when to do the core biopsy.
Okay. All cases you'll go for core biopsy. All cases you go for core biopsy. Okay. You palpate, you go for core biopsy.
Okay.
Okay. Non-palpable mass,
Okay.
It is rarely you find this, and we will not face any question here, because non-palpable mass, you may find it in screening programs that women above 40, 45 going for screening problem, and through mammography, you can find like spicules or something like minute calcification.
Yes.
And this has
Calcification.
yeah, sometimes they take biopsy, ultrasound or under mammographic guided. They take a biopsy as like multiple biopsy blindly, and I don't think this is practical even. But what we are going through in our study and our schedule here, he was talking about a mass. When to do a core biopsy for all cases. When to do excisional biopsy, sometimes in young females with a palpable small mass, and by examination and by ultrasound, mostly it's a benign. Mostly it's a benign mass, like fibroadenoma, and you will not find this except in females from 15 to 25. Okay, and by ultrasound, this is mobile mass, slippery mass, and you do ultrasounds well circumscribed and in a small part or in one quadrant of the breast. What you'll do for an excisional biopsy. No need to do the fine needle, as every finding according to the age, the ultrasound, and the examination, you go about more than 90% for non-malignant. Okay? Except you find lymph node together, and this is very rare to find this. If he tell you you find lymph node, no, you have to take a biopsy. Okay? Here is all the scenarios are so simple and so direct. Okay?
Okay, thank you.
Okay. Okay, next question. Dr. Farah.
I don't see the screen. Okay, fine. Now I see it. A 27-year-old lady presents with a breast lump. She has previously undergone a breast augmentation with an implant. Which of these imaging techniques is the most appropriate next step? Number 1 is ultrasound. Number 2 is CT scanning. Number 3 is MRI. Number 4 is PET-CT. And number 5 is mammogram. So she's 27-year-old, so we will go for ultrasound.
Yes, exactly. According to, yes, ultrasound. By the way, this is somewhat confusing question, because sometimes
he asks about the implant also, but since we don't have to see anything about the implant, so we don't go for MRI in this.
Yes, okay. Some doctor just see implant, okay, go for MRI, and this is true. If we have implant, we go for MRI for any problem or complication. But if we just asking about the breast, and I'm searching for a lump, okay?
Yeah.
I'm not looking for the implant itself. I don't have a complication with the implant, so I go for MRI. The lady normally accidentally come with a breast lump together that she have a history of implant before. So as a normal lump, I'll go for ultrasound. Okay, as a normal lump in a 27-year-old lady, I'll go for an ultrasound. But if I doubt a problem by the ultrasound related to the implant, I'll go for MRI. Okay.
Okay.
I have a personal case about 2 years ago, the same. She has an implant, she about 30 years. And after the implant, she has some inflammation and some redness and some swelling, fluctuant swelling in the breast. We did ultrasound, we found some collection. Without this, maybe about 1 month after the implant, without that maybe reaction or blood or bleeding or something, we did aspirate. we found it's clear fluid, ultrasound guided away from the implant, but we have, because it's around the implant, we have to do an MRI to make sure that the implant is not ruptured or nothing happened important, or nothing just spoiled the implant inside, because rupture of implant is very common sometimes to happen. Okay.
Okay.
So ultrasound, simply we'll do ultrasound. Okay, next question, Dr. Ghada.
Okay. A 52-year-old woman with a non-Hashimoto's thyroiditis presents with neck swelling. She describes it as a rapidly increasing in size over 3 months, and she complains of dysphagia to solids. On examination, there is an asymmetrical swelling of the thyroid gland. What's the most likely diagnosis? Anaplastic thyroid cancer, follicular thyroid cancer, papillary thyroid cancer, lymphoma, or toxic adenoma. Lymphoma. She has a history of Hashimoto thyroiditis, so most likely lymphoma.
Yes.
Okay. Any other answer?
No, she's right. It's lymphoma.
Yes, okay, exactly. About thyroid, yes, Dr. Muhammad, yes, lymphoma. About thyroid, also simply want to tell you, just you want to do, I forget to tell something about breast. What is the most common cancer breast in the middle age, or invasive ductal carcinoma? And what is the most common malignant tumor in thyroid?
Papillary carcinoma.
Papillary carcinoma.
Papillary carcinoma. Then
Follicular.
Then follicular carcinoma. He wants to know this basic. So if you found a patient, he is papillary until, especially in young patient, it is papillary until proved otherwise. And mostly follicular carcinoma come over a nodule or a simple nodular goiter or toxic nodule or something like this. You find previous history of nodular goiter and then superimposed like cancer, follicular cancer. Okay, or sometimes it is de novo from the start. But the most common is papillary carcinoma. Yes. Okay, he wants to know how is papillary spread. Most common
lymphatics.
Yes, route of spread of papillary is lymphatic.
Lymphatics.
Okay, so papillary, Y, ends with Y. So lymphatics, LY will be the most common. And the most common route of spread for follicular?
Hematogenous.
True. So it is follicular, red, blood. It will go for red. Follicular, and with R. So it will spread with red, with blood. Okay. Also, medullary, most commonly with?
Lymphatics.
Lymphatics also, medullary, and with
Central compartment.
Yes.
Sorry?
Central compartment of lymph nodes.
Exactly. We'll go for, we just need simple. Go for lymphatics. And anaplastic, most common route of spread?
Local
spread.
Local invasive.
Local invasive direct spread. Okay. This is maybe simply what you want to. He wants to know also that Hashimoto thyroiditis, we have many questions about Hashimoto. That in Hashimoto thyroiditis, most commonly you'll find the thyroid function test is low or high?
Low.
Low. It starts with high. By the way,
hyper and
yes.
First hyper, then hyper.
First hyperthyroidism and then followed by hypothyroidism.
Yeah.
Yes. It passes through many. Yes, it is simply passed through different stages. It starts with high, then back to normal, then settled on hypothyroidism. So if the patient is hypo, so you Hashimoto will be mostly hypo, okay? And then if it is passed for malignancy, it will pass to lymphoma.
Lymphomas.
Okay, because even in the histopathology or in the diagnosis of Hashimoto in histopathology, one of the main findings you for dense lymphatic infiltration. So we need to go for malignancy to go for lymphoma. And one of the main things to diagnose Hashimoto thyroiditis, what you will find antibodies in the blood.
Antimicrosomal antibodies.
Peroxidase, thyroid peroxidase antibodies. Most common, TPO. Thyroid peroxidase antibodies, I think this is the most common antibodies you'll find in thyroid, in Hashimoto thyroiditis.
Okay.
Peroxidase antibodies. And some people ask for this antibody during the routine tests for the thyroid function test. This is simply what he wants to know about thyroid, by the way. And then I think we have in head and neck about injury of thyroidectomy and what is the complication of thyroidectomy and nerve injury and something like this. I think we discussed this last session about head and neck surgery, yeah?
Yes.
That's all about thyroid he wants you to know. So simple and so clear and so direct, by the way.
Okay.
Okay?
Okay.
Maybe here is something important also. He wants to tell you that is a B-cell lymphoma. Non-Hodgkin's B-cell lymphoma, by the way. Okay, because I think I did see this question in one of the recalls before. He wants to know the type of lymphoma. It's B-cell lymphoma. Okay?
Okay.
Non-Hodgkin B-cell lymphoma.
Okay.
Okay, so it's clear. If we fail, I think this is all the related question we will face. If we find any new, we will discuss also as well. Next question.
A 34-year-old female presented with the thyroid nodule. She has a family history of the thyroid disease, and both her sisters have undergone thyroidectomized. Her past medical history include hypertension, which has been difficult to manage. What is the most likely underlying thyroid lesion? Papillary thyroid cancer, follicular, medullary, anaplastic, and lymphatic papillary. Thyroid disease of both her system. Hypertension, which has been difficult to manage, with most likely. Okay. It is a medullary thyroid cancer, see.
Yes.
It is?
Part of the men, yeah.
Men syndrome.
Yeah.
So it is?
See.
Men
See,
type 2. Medullary.
Exactly. Men type 2. Okay. Exactly, men syndrome, yes. We discussed this also in last session about, he said, what's the difference about the familial and sporadic medullary? Anyone remember?
Familial.
Just
There are
please
many
repeat the
families.
question.
Sorry?
Repeat the question, please.
We said last time how to differentiate between
Yes.
familial and sporadic medullary thyroid cancer.
Okay. Okay, familial, it occurs in the same family and in younger age and associated with
Yes.
other autoimmune disease. While sporadic can occur in as a new mutation in the same family and in more advanced age, and sometimes multifocal. Multifocal disease.
Which one is multifocal?
Sporadic.
Familial. Familial is multifocal, but the sporadic, mostly it will be presented without any family history, and most will be a solitary nodule. Okay. Anyone has another opinion or can't remember? What according to my memory and according to my study, I remember that solitary will be most. Okay, just a second. I think I have this note before in my notes. Yes, sporadic will be unilateral solitary nodule. In main familial syndrome, it will be bilateral multicentric lesion. Okay. Okay. So here we have
multifocal. Okay.
Multifocal, multicentric, and bilateral. The sporadic will be mostly solitary nodule. Okay.
Multicentric and bilateral. Yes. Yes.
Okay. By the way, Min syndrome is very important. Min 1, Min 2, A and B, very, very important. And we have many questions in the exam, and they have many questions in recalls as well. You have to put always in mind, because he tells the patient has a thyroid swelling and has hypertension, what you expect, has what will be your next investigation, and so on. And maybe asking about morphinoids, habits of the body, and so on. So you just have to relate between medullary thyroid cancer and pheochromocytoma as well. We will face many questions here. If we didn't find it here, we will find it in recalls, inshallah. Okay?
Yes.
Just you have to keep some topics you have to keep in mind, like your name. You can't go exam without. Like Min syndrome, part A and part B. There is no excuse that you can't put in like an image in your mind. You have no time to think. Galactoscoma scale. You have no time to think. You have to keep it in your mind like your name.
Yes.
Okay?
Yes.
Next question.
Yes.
Dr. Ghada.
56-year-old woman has undergone a wide local excision and axillary lymph node sample. The histology shows a 2.5 cm invasive ductal carcinoma, grade 1, which is completely excised. None of the axillary lymph nodes show evidence of metastatic disease. What's the most appropriate course of action? Arrange routine surgical follow-up, complete mastectomy, radiotherapy to breast and axilla, administration of tamoxifen, or radiotherapy to breast alone. So wide local excision and axillary lymph node biopsy. This is breast conserving surgery, and lymph node was negative. So we need the third part of action, which is radiotherapy for breast only. The last option, radiotherapy to the breast alone.
Yes.
No need for mastectomy.
Yes.
It's a small lesion, less than 4 cm, completely excised. It's grade 1, so no need for mastectomy. So just radiotherapy for
axillary
breast.
Axillary lymph nodes are negative.
No evidence of negative axilla. So
okay, so what we need completion.
Yes,
in wide local excision, we just go for radiotherapy.
We need radiotherapy. Yes.
Okay, for the breast alone. Okay.
Yes.
Exactly. Just we need radiotherapy after any conservative breast surgery, full excise, and we don't have any axillary lymph node. We go for radiotherapy. Okay.
Yes.
Next question. Dr. Duffer.
20 years old lady presented with the lump in the upper outer aspect of the right breast. Examination, she has a fixed mobile mass in the upper outer quadrant on her breast. What is the most likely disease process? Fibroadenoma. It is a typical ductal hyperplasia, breast cyst, ductal ectasia, fibroadenoma fat, necrosis. So it is fibroadenoma. T.
Exactly. This is typical picture
Yes.
in a girl, 20 years, lump, upper outer quadrant, and examination. It is mobile and slippery. We didn't go for what is the main treatment for this patient?
Reassurance.
Excision.
No. Reassurance and breast self-examination.
It is not mentioned the size, first of all. There must be a size. If large one, we
Okay.
need to excise it.
Different, yes. It's different policy from different clinics and different places. Sometimes
Yes.
some hospitals or some policies go for excisional biopsy, and it is the most safe, and it's maybe my policy, or I don't wait because she is young age, 20 years, and she has a mass, and she has a very excisional biopsy, and she have a very long lifespan. A very long lifespan. I'm completely against reassurance. Completely against reassurance in any palpable breast mass in a young patient. Okay, so many say like this make exactly like those who find one or two stones in the gallbladder, and they tell, okay, reassurance and follow-up. Reassurance for what? Sooner or later you'll go for an excision. So if this patient is 20 years and then you have a mass, palpable mass,
yes,
0.5.
it will be uncomfortable. Yes, discomfort for the patient and causing her worrying about it. So in SRB and Washington manual, I think it's mentioned if it is more than, or it's about 5 cm, you can excise the lesion. If it is less than 5 cm, so we can leave it. Yes.
If it is 0.5, I'll excise it. Okay, is it nice?
5 millimeter. Yes.
5 millimeter, yeah.
5 millimeter, yeah.
Not 5 centimeter. Okay, maybe cyst, but if it is a mass and small, is it logic to tell the patient every year, come to me to make an ultrasound? For what, doctor? If it started to turn malignant, we remove it. So it is unlogic. Okay.
Yes.
So,
but books don't mention that. Books don't mention.
By the way, they will not discuss this issue here. We have no question. I'm talking about the clinical and a practical issue.
Okay.
Okay. It's unlogic to leave a patient with a mass about 20 or 25, because as the patient gets 35 to 50 or she gets pregnant, this mass will be worsened, and you'll go for you'll have to excise this mass sooner or later. So it is not logic to leave the patient about 20 years without excision of the mass, with a mass in her breast. Okay.
Okay.
Forget about this. Just keep in our main scenarios and schedules. Okay, next question.
Yes.
Dr. Burhan.
All right. 52-year-old woman presents with an acutely ischemic right arm. She is found to have fast atrial fibrillation. Her blood results reveal a free T4 level of 20, a TSH level of 0.01. What is the most likely diagnosis? A. Poor compliance with thyroid medication, thyrotoxicosis, multinodular goiter, sickly thyroid syndrome, Hashimoto thyroiditis. So this is thyrotoxicosis.
Okay.
Yes,
Exactly.
thyrotoxicosis.
Exactly. So
fibrillation is caused by thyrotoxicosis.
okay, sorry.
Atrial
AF, the patient.
fibrillation, one of the causes
Okay.
is
Yes,
thyroid.
the patient has AF, and he tell you she has a high T4 and a low TSH. By the way, in the exam, all the parameters will be with the normal values. Don't be disturbed with this. All
TSH level is also very low. The feedback.
TSH is low and T4 is high, and it can't be multinodular, it can't be secure thyroid syndrome, it can't be Hashimoto, it can't be poor compliance with thyroid medication. This patient has a very high thyroid toxicity. That's why she has AF, and it is she's very risky to develop any embolic lesions. Okay, that's why she has acutely ischemic right heart. So thyroid toxicity is the right answer. Next question, Dr. Ismail.
Okay. 70-year-old lady with metastatic breast cancer is admitted to hospital, confused and acutely unwell, with nausea and vomiting. Her vital signs are within normal limits. What abnormality is most likely to contribute to her clinical condition? Hyponatremia, hypernatremia, hypocalcemia, hypercalcemia, hyperkalemia. I don't know actually. Hypokalemia.
Okay.
Hypokalemia.
Okay.
Hypercalcemia.
Dr. Hada say hypercalcemia.
Yeah, it's
Yes, sorry.
hypercalcemia.
I'm not unmuted, sorry. I was just thinking in loud voice.
Okay. Okay. We all thinking with you, Dr. Hada. Dr. Farah, hypercalcemia. Okay.
Yes.
Exactly. In patient with metastatic breast cancer, mostly one of the paraneoplastic syndromes with this, it will be hypercalcemia, and the patient mostly come with confusion and a picture of hypercalcemia. Okay, mostly metastatic tumors in the exam. He wants to ask about the metabolic disturbance or the electrolyte disturbance. He wants you simply to know that hypercalcemia is one of the most common electrolyte disturbance in patients with metastatic tumors, especially like breast cancer, osteolytic metastatic cancers. Okay. So, and what is our main intervention here? What is the main treatment here?
IV fluids. IV fluids and followed by bisphosphonate.
What is IV fluids will you give?
Normal saline.
Normal saline. And then followed by
bisphosphonate.
Normal
saline.
Sorry.
IV normal saline.
It's according to the level of the calcium. If there are criteria for giving, firstly, IV fluids. If it is more than the normal by 1 degree or others, so giving IV fluid. If not, or simple hypercalcemia, we can giving the treatment for the hypocalcemia straightforward.
Okay. Most questions here asking about hypercalcemia in MRCS, past test and recalls and all exams. He wants you, and even part B, he tell you hypercalcemia, what's your definite management? He wants you to tell IV normal saline. Okay.
Okay.
Maybe some different levels, and we just don't go for more details about the level of the calcium and what to give. Will you give aldronate? Will you give IV saline only? Will you give calcium chelating agents, and these details may he ask you in part B when he asks you in details, but you have to start with IV normal saline for the patient, followed by the definite management for the calcium as well. Okay, so maybe, or you are right, Dr. Doffer, but just for no confusion, we just want to tell any hypercalcemia patient come with hypercalcemia, you have to give an IV saline, and we find this many questions and recalls, many questions in exam in eMRCS as well. Part B, the station of hypercalcemia or any tumor. He wants you to just mention IV normal saline is the first line of treatment. Okay, next question. Dr.
63-year-old man is recovering following a protracted stay in the intensive care unit, recovering from an anastomotic leak following a difficult transhiatal esophagectomy. His progress is slow. In the ICU, doctors receive the following TFT results. TSH is 1.0, free TST4 is 8 microgram per deciliter, T3 is 1 microgram per deciliter. What's the most likely interpretation of these results and findings? Hyperthyroidism, anxiety state, sick euthyroid, normal euthyroid, and hypothyroidism. So he has low TSH. Okay. So the patient is a case of sick euthyroid.
Sick
euthyroid.
Yes. Okay, this is a very easy question, by the way. In the exam, he will tell you patient in the intensive care or sick patient post-operative, and he will give you all parameters of the thyroid, completely all are low, TSH low, free T3 and T4 mostly low or just in the lower limit. So this is a sick thyroid syndrome. Okay, very, very easy question. And I think I have this question in my exam, by the way.
Okay.
Next question, Dr. Ghada.
A 29-year-old man presents to the clinic. I lost the screen, just wait. Present to the clinic with a recurrent thyroid cyst. It has been drained now on 3 occasions. Each time the cyst is aspirated and cytology is reassuring. What's the most appropriate course of action? Reassure and discharge, resection of the ipsilateral thyroid lobe, inoculation of the cyst, thyroid, photothyroidectomy, or radioisotope scan. Lobectomy, resection of ipsilateral thyroid lobe. It's a recurrent cyst with benign features, so lobectomy.
Okay. So it is unlogic to complete after 5 times or 3 occasions on aspiration. It's unlogic to continue aspirating more than this. And there is nothing called inoculation of the cyst, and we will not do total for just a small cyst. So it is resection of the ipsilateral thyroid or hemithyroidectomy.
Ipsilateral lobe, yes.
So it is hemithyroidectomy. Okay.
Yes.
Next question. Dr. Doffer?
Yes. 82 years old woman from nursing home admitted to the orthopedics ward for hip fracture. She is actually confused and agitated. Her calcium 2.9 0.95 elevated, and parathyroid hormone 12 elevated. What is the best course of action? Administration of the intravenous dextrose, administration of the intravenous crystalloid, systemal scan, administration of the intravenous colloid, emergency parathyroidectomy. So administration of the intravenous crystalloid B.
Yes.
Okay. All have the same answer?
Hypercalcemia. Yes.
Yes. Okay, I think it is not so high. It is just 2.3 from the normal is 2.2, and you want you to start with intravenous crystalloid or intravenous normal saline. Okay, next question, Dr. Burhan.
All right. A 45-year-old man is referred to the breast clinic with gynecomastia. He takes the drugs listed below. Which one is least likely to be the cause of his symptoms? Least likely. A. Spironolactone. B. Carbimazole. C. Chlorpromazine. D. Cimetidine. E. Methyl-dopa. So I think it's B, because spironolactone, cimetidine, methyl-dopa are confirmed one of main causes of gynecomastia. I'm not sure
Okay.
about chlorpromazine too.
Okay. By the way, questions about pharma and exam are not so many, so maybe 4 or 5 questions ask about some side effects of some drugs, and it's a little bit confusing. So we just trying to know as many questions as we can. We don't need to have any details. So I think questions about pharma, just keep it in your mind like it is. Okay.
Yeah.
By the way, if it came in the exam, it will come with the same drugs and with the same order mostly. So it will be spironolactone, carbimazole, chlorpromazine, cimetidine, and methyl-dopa. So carbimazole is the one which will not cause gynecomastia. And I think it's not logic to know all these mnemonics. You will for sure you will forget in exam, except you are a genius, because you have many questions, by the way, about pharma in different places ask about some drugs or some side effect. So just keep questions of pharma, don't confuse yourself. You have many questions, need to concentrate and to understand more than pharmacology questions. Okay, next question, Dr. Ismail.
Okay. 72-year-old female is found to have malignant lesion in her left arm. She had mastectomy of the left breast 10 years ago and has chronic lymph edema of the arm. What is the most cause of malignancy? Lymphangiosarcoma, lymphoma, myeloma, angiomyolipoma, giant cell tumor. Okay. This is the lymphangiosarcoma.
Exactly. He wants to, by the way, it's rarely find something like this, but he just wants to tell you that long-standing chronic edema or chronic lymphadenitis can cause lymphangiosarcoma. It's a rare condition. I haven't seen it in my life, by the way, but he wants to tell you if it is transformed into a cancer or it is moved to a cancer, it will go for lymphangiosarcoma. Next question, Dr. Farah again.
A 39-year-old lady presents with a mass lesion in her right breast. Clinical examination, biopsy, and imaging confirm a 2.5 centimeter lesion in the upper inner quadrant of the right breast and 1.5 centimeter lesion at the central aspect of the same breast. Her axilla shows lymphadenopathy and a fine needle aspirate from the node show malignant cells. What is the best course of action? A is a simple mastectomy with axillary node clearance, wide local excisions of 2 lesions in axillary node clearance, simple mastectomy in sentinel lymph node biopsy, wide local excision of 2 lesions in sentinel lymph node biopsy, radical mastectomy and axillary node clearance. So my answer is A, simple mastectomy and axillary node clearance. Yes, sir.
Okay.
Yes.
Can you
Yes, I
explain why
agree.
did you choose this answer?
There can be two answers for this, A or E, but E is not done in this case because there is no evidence of any local invasion, local spread.
Okay.
So in
this
these
is
cases, mastectomy is done. Plus axillary node clearance is done because there is a clear evidence patient has an axillary node and that is diagnosed as malignant. So there's no idea of doing a sentinel lymph node biopsy or axillary node clearance. We straight away go for axillary node clearance only.
okay. So it is a multifocal lesion, one peripheral and one central. We have 2 lesions. Okay. So it is not one lesion. So we have to go for mastectomy. We can do wide local excision. So B and D will go out of our choices, and then we still have A and C and E. Post simple mastectomy, and one is axillary. We said also radical mastectomy. It is not. They say it is historical and gives the same prognostic, same prognosis and same results and same life expectancy, the same like simple mastectomy. So it is no more than now in UK. We have simple mastectomy with sentinel lymph node. Okay, we already did fine needle aspiration and we have the result of malignancy. So sentinel lymph node, we do it when we can't palpate or we can't see by ultrasound any lymph node. We can do it intraoperative to make a frozen section, and this is something like alternative for the fine needle. But here we can see and feel the lymph nodes, so axillary node clearance. So simple mastectomy and axillary lymph node clearance is our right answer according to our scenarios and according to the protocol we agreed about. Okay?
Okay. Okay.
Next question, Dr. Reda.
Okay. 55-year-old woman presents with the nipple discharge. On examination, she has a slit-like retraction of the nipple. In the center of this area is a small amount of cheese-like material. No discrete mass lesion is palpable in the underlying breast. Which of the factors listed below is the most strongly associated with developing of this condition? BRCA1 positivity, smoking, alcoholism, obesity, type 2 diabetes mellitus. Smoking, she has ductectasia. She has no palpable mass, and there is a slit-like retraction with cheesy material. So smoking is a risk factor for hair condition.
Okay, here he wants you to know something called ductectasia. And ductectasia, one of the what's called chronic non-specific inflammation of the one duct of the breast or the nipple. That's chronically produce a cheesy material, and it is highly associated with
smoking.
Smoking has a very strong relation to smoking. That's what he wants to know about. Okay.
Dr. Ravi,
yes,
I have a question.
Yes. Yeah.
I just want to ask, what are the pathognomic signs of ectasia, ectasia dilatation? How does this question suggest that a woman has been suffering with ectasia.
Again, I can't get you.
He's asking about the pointers towards duct ectasia in this question.
About duct ectasia?
Yes.
Yeah.
How you could know this is duct ectasia?
Yes.
Yeah.
Okay. As I told you, he is treating you like you are a dentist. Okay. Simply, he wants to tell you that a cheesy material from the nipple, it is duct ectasia.
Yes.
Okay.
Yes.
Really, he is treating us as we are still students, and he want to go very superficial. Blood from a duct from the nipple, so it is duct papilloma. Cheesy material, it is duct ectasia and related to smoking. But really, he wants you to know this information only. He will not go for more details about duct ectasia, and it is. I just wanted to tell you some more information. This chronic non-specific inflammation, one of the main histology, dense lymphocytic infiltration, and it is associated with smoking. I just want you to. He wants you to know about different type of discharge from the nipple. If it is milky, so it is the galactorrhea. If it is cheesy, so it is duct ectasia. It is bloody, so it is mostly duct papilloma. Maybe cancer according to the age and according to the sign. If it is serous, maybe also some sort of galactorrhea, but it is not so milky. Whatever, he just wants you to be more simple. And I think we passed more than about 15 to 20 questions now, and all questions are more simple and very simple, like the algorithm or the protocol we agreed or we discussed in the start of our discussion. Be very simple. You will ask only simple questions, by the way. Okay? Put this in your mind, and you will find your study is so easy. When you look for the first time to the eMRCS, and all of us before, we guess it is like something like hilarious, and it's very difficult. And some of my friends, like orthopedic, urologist, gyna, call us, what is this? Is this hilarious? We can't understand. This is more sophisticated questions and more deep questions. No, really, when you start to study, you'll find it's complete superficial questions. Okay.
Right.
When you find in your question cheese-like material, go for duct ectasia. He will not confuse you by very rare tumors that is cheesy. No, but we histopathology find it cancer. No, it is not for you. You are not the candidate for this. Okay.
Yes.
Next question. Who's there? I forget who's there.
Dr. Ismail.
Dr. Ismail.
Okay.
Okay.
A 56-year-old man is investigated with an abdominal CT scan for a change of bowel habit towards constipation. It shows no colonic lesions. However, a right-sided adrenal lesion is noted and measures 2.5 centimeters in diameter. What is the most appropriate course of action? Arrange an MRI of adrenal gland, arrange an adrenal ultrasound, arrange an image-guided core biopsy, undertake adrenalectomy, arrange hormonal assay. Okay. This is incidental finding of adrenal gland. So arrange adrenal ultrasound.
You already did CT, which is more higher investigation, ultrasound or CT.
Of course, okay. So,
Investigation,
hormonal
hormonal.
Hormonal assay.
Yes, exactly. Okay. What is the information he wants to tell you here about adrenal tumors? You are a GP doctor and you did an ultrasound or CT for a patient and you find an adrenal mass. He wants to tell you the last two lines. The vast majority of small adrenal lesions are incidental. Okay, because most of them are benign and non-functioning adenomas. Okay. Let's see, no further investigation. Okay, I'll tell you no, it is not, but he's just concerned about the malignancy on surgical options of, and even he just starting to doubt about malignancy when you find this mass more than 4 centimeters. Unless
it's less than 4
it is a benign. It is a benign lesion, but you have to make sure with one type of test, which is hormonal AC. He wants you to do cortisol and catecholamines. That's all. Okay, because this is the most common tumors happened in the adrenal gland is pheochromocytoma. But maybe this, he wants to, vast majority of any mass in the adrenal gland is benign adenomas and non-functioning. But if it is functioning, it will be pheochromocytoma most commonly. So how you can diagnose? You'll go for cortisol, morning and evening cortisol, and you go for catecholamine level in the blood and sometimes in the urine. Other than this, no. If you found this is functioning tumor or functioning mass, okay, we can go for more invasive investigation, like maybe you go for adrenalectomy, go for biopsy, according to the size and according to the doubt of the tumor. But keep simple, this non-functional. And by the way, I have this question in my exam. This is non-functioning adenoma. What you will do, just hormonal AC to make sure that this is not functioning mass. That's all. Okay, Dr. Farah.
Yes. A 59-year-old man is referred with symptoms of dysphagia. On examination, he has a large goiter, and on imaging, there is significant retrosternal extension in features of multinodular goiter. What's the most appropriate course of action? Total thyroidectomy, subtotal thyroidectomy, thyroid lobectomy, radioiodine, conservative management. I think it's total thyroidectomy, although I'm not sure because some books write subtotal thyroidectomy also. I go for total thyroidectomy.
Okay, this is a retrosternal extension, multinodular goiter. So there is no conservative management. There is no radioiodine. There is no lobectomy because it is a retrosternal. So lobectomy will have no benefit. Okay, and this is a generalized mass. It is not a focal mass in one loop. Subtotal thyroidectomy is not a practice nowadays. It's not a practice nowadays because if you found any problem in the thyroid, doing redo thyroidectomy is a nightmare. So even before, maybe sometimes even now in hyperthyroidism or thyrotoxic goiter, they always go for total thyroidectomy and replacement treatment. Subtotal thyroidectomy is not done nowadays, even in the protocols of the UK, because if any problem happens for the remnant of the thyroid in life, after few years, many years, is a nightmare to go again to remove the remnant of the thyroid. So it's easy to go for total thyroidectomy. Okay. As we said, radical mastectomy is historical. Also, subtotal thyroidectomy is historical operation nowadays. Okay.
Okay, thank you.
Okay. Next question. To Rada.
Okay. 58-year-old male is referred to endocrinology clinic for a parathyroidectomy by the F1 in medicine. His corrected calcium is 2.85 and PTH is 7.5 and 24-hour urinary calcium is 1.5. What's the diagnosis? Primary hyperparathyroidism, secondary hyperparathyroidism, tertiary hyperparathyroidism, familial hypocalciuric hypercalcemia, hypercalcemia associated with malignancy. There is hypercalcemia, elevated calcium, and parathyroid hormone with low urinary calcium. So familial hypocalciuric hypercalcemia, because in a primary hyperparathyroidism, only there is hypercalcemia and increase in parathyroid hormone with normal urinary calcium. In secondary, there will be hypocalcemia. In tertiary, there is increase in both calcium and parathyroid hormone. And there is no malignancy here for any clue for malignancy. So familial hypocalciuric hypercalcemia.
Exactly.
D.
And you, yes. Okay, here he wants to tell you calcium to creatine clearance less than 0.0.5 will confirm the diagnosis that because there is low calcium in the urine, and so it is not primary or secondary or tertiary hyperparathyroidism, is a familial hypocalciuric hypocalcemia. Okay, and this will be clear as he tell you in this scenario. Even if you can see this question, he give you the answer in the scenario. He tell you this is in spite of you have a very high calcium or high calcium in the blood, you have a low calcium in the urine. So from the question you will find it. What is the difference between primary, second, tertiary? Okay,
Yes.
You will find that hypocalciuric hypercalcemia, even if you don't know the question and you want just to choose the answer, for me, I'll choose familial hypocalciuric hypercalcemia. As I found in the scenario, I'll choose from the answer. Very simple, very simple, very simple. Okay, let's go for the next question.
Yes.
19-year-old lady is admitted to the intensive care unit with the severe meningococcal sepsis. She is admitted for tropic support and CT scan of the chest and abdomen is performed. Adrenal glands show evidence of diffuse hemorrhage. What is the most likely explain? Waterfield, Waterhouse, Frederick syndrome, Nelson syndrome, Walk-Weber syndrome, spontaneous bleeding into malignant lesion, spontaneous bleeding in the cyst. It's A. Waterhouse.
Okay, it's Waterhouse, Frederickson.
Yeah.
Frederickson, this is a Deutsch word. Frederickson or Frederickson, I think, syndrome, according to Deutsch language. Also, this is one of the questions that has no related questions. He just want to tell you this is a syndrome that's very common with Neisseria meningitis or Meningococcus Neisseria meningitis that having sudden bleeding with the infection. It happens bleeding inside the gland inside the adrenal gland. Okay. It will come with this scenario with this definition, by the way. I did see it once, maybe in the recalls, with the same scenario. The patient has meningococal sepsis and have diffuse hemorrhage inside the gland. This will be Waterhouse syndrome. Okay. Next question.
Okay. A 50-year-old lady is commenced on tamoxifen for the treatment of an estrogen receptor positive breast cancer. Which of the following malignancies are associated with tamoxifen use? Adenocarcinoma of the colon, Hodgkin's lymphoma, adenocarcinoma of the lung, ovarian cancer, endometrial cancer. Endometrial cancer. E.
Yes. Exactly. He just want to tell you an information here. He won't tell you that spite of tamoxifen is estrogen antagonist in the breast, but in some areas it is agonist for the estrogen and carries a high risk of endometrial cancer in females. Okay?
Yes.
That's the information he wants to deliver to you here. It is an antagonist on the breast, but it can be agonist for estrogen on the endometrial of the uterus. Okay. Next question.
A 48-year-old lady presents with discomfort in the right breast. On examination, she has a discrete, soft, fluctuant area in the upper outer quadrant of her right breast. Mammogram is performed and the halo sign is seen by the radiologist. What's the most likely explanation for this process? Breast cyst, fibroadenoma, radial scar, atypical ductal hyperplasia, ductal carcinoma in situ. So, patient has a fluctuant swelling and a halo sign, so it's a breast cyst.
Exactly. So it is a fluctuant.
Yes.
From soft fluctuant. It is not fibroadenoma. It is not radial scar. It is not atypical duct hyperplasia. It is not ductal carcinoma. So all these lesions are not fluctuant areas or fluctuant lesions. You just deal very simple with us again. If anyone just give him in the second year of medical school, he will answer it is a cyst without seeing any other answer. Okay, so simple and so
Yes.
clear and so direct. 5 questions for Dr. Farah's answer A. No, okay. Thanks for this analytic point of view, Dr. Dhafar. Okay, next question.
Okay, a 72-year-old woman presents with 2 breast lumps. She has a history of breast cancer in the opposite breast 5 years ago. What's the most likely underlying lesion? Invasive ductal carcinoma, mucinous breast cancer, comedotype ductal carcinoma in situ, invasive globular carcinoma, or cribriform ductal carcinoma in situ. It's multifocal and in the opposite breast. So invasive lobular carcinoma. D.
Yes, this is the idea he wants to tell you here in this question. He wants to tell you if I have a recurrent cancer in the other side or the other side of the breast, the other breast. So you are facing a multifocal bilateral cancer, which is most commonly is the globular carcinoma. Okay, he just wants you to
Yes.
know this broad information that lobular carcinoma or invasive lobular carcinoma is bilateral in nature. Okay, so
Yes.
simple about this information. Next question.
For me or for
Dr. Dafer, okay.
A 32-year-old woman presented with a tender breast lump. She has 2-month-old child. Clinically, there is the tender fluctuated mass of the hair breast. What is the most likely diagnosis or causes? Ductectasia, intraductal papilloma, breast abscess, breast cancer, fibroadenoma. So it is a tender breast mass, it is breast abscess.
Okay, this lactating woman,
Yeah.
or lactating lady with a fluctuating tender mass. So it is breast abscess. It is not ectasia, it is not papilloma, it is not cancer, it is not fibroadenoma. The same, you just want this is a fluctuant mass, so it will never any other lesion except for breast abscess. Okay. Next.
Okay, a 33-year-old lady attends the clinic with a 3-month history of palpitations and irritability. Her thyroid, parathyroid, and calcium are measured. Free T4 40, TSH less than 0.1, free T3 25, parathyroid hormone 10, calcium 2.12. Okay, what is the most likely diagnosis? Hypothyroidism, hyperthyroidism, hypoparathyroidism, hyperparathyroidism, euthyroid. T3 is high, parathyroid hormone normal, calcium 2.12, this is normal, free T4. I don't know, calcium is normal, 2.12.
Parathyroid and calcium are normal. So it is not parathyroid problem, okay?
Free T4 high, right? Hyperthyroid.
By exclusion, Dr. Ismail,
Yes,
parathyroid and calcium are normal, so it is not a parathyroid problem. Okay. Hyperthyroid. This patient is suffering from clinical picture of hyperthyroidism. T3 high and T4 I think it's high, but TSH is low. So it is a typical picture of primary hyperthyroidism. Okay, by exclusion. Nothing in the scenario he mentioned about the patient is sick or in the ICU or post-operative or something like this. So it is not a sick thyroid syndrome. And we excluded parathyroid. So it is a picture, even it's a hypo or hyperthyroidism, and from the scenario it is, and labs, it is a case of hyperthyroidism.
Okay.
Okay, next question.
A 30-year-old woman with recent diagnosis of Graves' disease underwent incision and drainage of a pilonidal sinus abscess 3 hours ago. She became agitated, confused, and is noticed to be jaundiced and sweaty. Her temperature is 39 degrees centigrade, pulse is 152 beats per minute, and blood pressure is 95/60. And ECG shows an irregular ventricular rate with absent P waves. After resuscitation, what is the most important next step in the management? Bile acid sequestrants and glucocorticoids, bile acid sequestrants and iodides, beta adrenoreceptor blockers and thionomides, beta adrenoreceptor blockers and iodides, thionomides and thyroidectomy. So I think it is beta adrenoreceptor blockers and thionomides.
Exactly. This is a case of
Thyrotoxic
crisis.
Thyrotoxic
crisis. By the way, this question is in, I think, April or September 2018. Okay. And it was somewhat confusing about what to choose beta adrenoreceptors and cyanoamides or to choose it with iodides. Beta adrenoreceptor, okay, we all agree that the patient has some ECG changes, okay, and tachycardia and AF. So we have to go for beta adrenal receptor blocker. But to give cyanamides or to give iodine, here is the answer is just cut. It is antithyroid drugs. You have to give antithyroid drugs. It was a little bit confusing, but this question came with the same scenario and the same choices in 2018. Okay, so beta adrenal receptor blocker and cyanamide is the right answer. Not to forget it when we face this question again in recalls. Okay, next question.
Okay. 18-year-old female notices, yes, an 18-year-old female notices an untender mobile breast lump. Clinically, there's a smooth lump which is not tethered to the skin. What is the likely cause? Fibroadenoma, atypical ductal hyperplasia, ductal carcinoma in situ, lobular carcinoma, or lipoma. It's mobile in a young patient, fibroadenoma.
Exactly. Young age, most common lesions and most common disease in the breast lumps in very young age between 15 to 25 is the fibroadenoma or breast mouse. Yes, exactly. Okay, next question.
A 43-year-old woman, he had a recurrent episode breast infection. She has received multiple courses of antibiotic and troubled by the persistent green nipple discharge. Clinical examination revealed a green nipple discharge but no discharge lump. Image with mammograph and ultrasound reveal ultrasound 2, grade 2 M2. What is the best course of action? Undertake humidify the procedure, undertake microidectomy, arrange for breast MRI, express fluid for cytology, prescribe denazole. So there is I choose undertake Hedefield procedure.
Okay, all agree?
Yes.
Mike, 43, multiple course. Hadfield's procedure.
Hadfield, yes.
Yes, Hadfield procedure, exactly. Okay, he won't tell you here ductictasia or complicated ductictasia. Okay, we go for Hadfield's procedure, and he will discover in another question that if it is not complicated or just one time or just one episode of greenish nipple discharge, even it is by history or by examination, you doubt about ductictasia, you'll go for just conservative management with follow-up. But if it is complicated or troubling for the patient, disturbing the patient, you'll go for Hadfield's operation, which is a wedge resection from the nipple and part of the areola as well. Okay, this is a wedge resection from the nipple and areola and maybe part of the breast tissue to remove all the dilated ducts. Okay?
Yes. Okay.
Okay. I think we are about this, maybe almost 2 hours now, maybe a little bit less. And we finished about half of our question. We have about 65, 67 questions, and we finished about 35. And we have the same. I think we can continue tomorrow. Okay?
Okay.
So I don't like to make videos more than 2 hours. So it will be easy and more comfortable to you. If you want to listen or view it again, it will be easy to revise. Okay?
Okay.
Okay, so we can start early tomorrow and continue another one. We will have more questions tomorrow. Maybe it will be more short and it will be more easy. Question will start to be repeated, and I think we discussed the main ideas in the first half of our discussion. Okay.
Okay.
Thank you for all. Wish you
Thank you so much.
good health and good work, and be safe in your work, and wish you all healthy, and wish this disaster to be ended soon, inshallah.
Inshallah.
Thank you for all. Have a good night and happy dreams. Thank you.
Thank you.